Thank you, Anna. Well, it is a great pleasure of mine to introduce Dr. Susan Hintz today. Dr. Hintz is the Robert L. Hess Family Endowed Professor in neonatology. She is the Associate Chief of Academic Affairs for the Neonatal and Developmental Medicine Division, and a professor by courtesy in the Department of OBGYN, which you'll learn why in a minute. She directs the Fetal and Pregnancy Health Program at LPCH, which I'll talk a little bit more about. But just important to know that she's a neonatologist and perinatal epidemiologist whose research focuses on understanding and improving morbidities and neurodevelopmental outcomes for extremely premature and high-risk infants, including the use of neuroimaging as a biomarker. She's served as the lead PI for neurodevelopmental outcomes within the NICHD Neonatal Research Network, and is the PI and medical director for the CPQCC high-risk infant follow-up program, which we'll hear more about today. And really critically to anyone who practices at LPCH in Stanford, she has led the creation of the Fetal and Pregnancy Health Program at Stanford that she's directed since its inception. And this is really an innovative and critically important program that integrates care from diagnosis through delivery planning and postnatal care for a lot of very complex newborns. And if anyone was here at LPCH pre-Susan, they know that this was something that when we didn't have the beautiful streamlined system, we had all the right people in place, but not the beautiful streamlined system, and kind of growth that allowed this whole program to really explode, and everything works very smoothly and well. She's received so many honors and awards along the way, including the Distinguished Medical Staff Service Award at LPCH and a Harmon Faculty Scholar Award. Dr. Hintz was born, raised, and trained at Stanford from undergrad, medical school, residency, and fellowship. Little known fact, she was, I think, 2 years ahead of me at Gunn High School. I remember her. She doesn't remember me, probably because she was the impressive upperclassman, and but that's it. So please join me in welcoming Dr. Hintz as she discusses how we can really reimagine high-risk infant follow-up. So thank you so much, Susan.
Well, thank you so much, Deirdre. That was such a nice introduction. And I will say it's apocryphal, the part that I was born here. I was not born here. So someday I can tell you the whole story of my life before I came here. But anyway, thank you all very much for the honor of inviting me to speak today. I will say this is probably a bit of a departure from most of the Dunlevie presentations, but obviously it's a topic that many of you are very interested in, as high-risk babies result sometimes from high-risk pregnancies. And we're going to focus today on mostly the California high-risk infant follow-up program that I'll talk a little bit about, or mostly about during this presentation. But I hope first to kind of convince you that what we need to do in high-risk infant follow-up is really look at that through the lens of quality improvement as we seek to reimagine high-risk infant follow-up. So many of you are well aware of quality improvement initiatives, and it's really had a very robust history in neonatology. And I will not speak to CMQCC, which obviously is a critically important feature of California's landscape of quality improvement, and actually nationally as well. But I'm going to focus on neonatology. And this has really exploded over the last 20 years, in a large part because of the many randomized controlled clinical trials that have been done, very frequently multi-site trials in neonatology, that has led to translation to quality improvement. And among many quality improvement initiatives or collaboratives includes California Perinatal Quality Care Collaborative, CPQCC. But the majority of quality improvement in neonatology has really been focused on short-term outcomes and NICU-based interventions. And this on your right is from the CPQCC, led by my colleague Henry Lee, who showed that over the years, and we would say in part due to the many quality care collaboratives that were rolled out over this time in the CPQCC, the adjusted rate of survival without major morbidity at the time of discharge increased for very low birth weight infants. But what about quality improvement beyond the NICU exit doors? This has really not been thought of very much in neonatology until very recently. But I will say that it must be considered because high-risk infant follow-up, it critically plays an increasing role in obtaining the primary outcomes for clinical trials and for playing a role in quality improvement of what's going on in the NICU. The vast majority of clinical trials in neonatology now have 2-year outcomes, usually neurodevelopmental outcomes, as primary outcomes or main secondary outcomes. So it makes a great deal of sense to think about how we can apply quality improvement and extend that beyond the NICU to the home and community. So for this talk and for this audience, I thought I would just sort of frame what is high-risk infant follow-up, and many people refer to it as NICU follow-up. It might be, I would say, considered maybe an outgrowth of quality improvement in neonatology, in that we seek to understand what our interventions and changes in care in the NICU are doing later on. And there's no doubt that the AAP and other key joint work groups have recognized the central importance of integrating follow-up care for high-risk infants, and there have been statements to that effect. However, and I will say this is the takeaway message from this slide, there has been no national standard of care for what HRIF means or what NICU follow-up really means. So if you know one high-risk infant follow-up program, you know one high-risk infant follow-up program. There is substantial variation in approaches and in outcomes focus, and many people, in fact, think of high-risk infant follow-up, when they think of it at all, as very narrowly focused on neurodevelopmental outcomes. And I hope I'm going to be able to convince you otherwise as we go on. But this really tees up an important opportunity for improvement in high-risk infant follow-up, which is how can we make connections to share with each other our outcomes and what we're doing, and why is that important? So before I get to California, I will say that there are other groups that have been trying to move in this direction. The Vermont-Oxford Network has put together an extremely low birth weight follow-up sort of work group. This is kind of not required, but some groups are involved in that. Which support some data items that are given. So this is great. But more recently, the New England Follow-Up Network has attempted to be a little bit more comprehensive, but again, just obtaining data at 2-year follow-up, but at least for sort of the New England area. So, and also these groups have been very limited in terms of the inclusion criteria. So for the extremely low birth weight follow-up in Vaughan, it obviously is that. And for the NEFUN group, it has been also a gestational age group, again, very low, extremely low birth weight. So that brings us to California, and I'm really going to spend the majority of time speaking about the California high-risk infant follow-up program. So first, I'll give you a little bit of background. I think many of you know about CMQCC, but I want to give a little bit of background about CPQCC. This was launched in 1997. It now includes more than actually 150 hospitals at this point, and it captures more than 95% of all VLBW infants born in California. So this really makes it a population-based data set. And it really has been from the beginning a framework for quality improvement. There have been multiple statewide QI collaboratives. There are multiple toolkits and multiple tools and reports that are site-specific that allow for site QI and PI. And importantly, the California Children's Services has mandated since 2004 that any NICU that hopes to obtain CCS approval needs to be part of CPQCC because of that quality improvement component, and because of our partnership with the state, helping the state to understand where quality improvement options exist. So the CCS, we're very lucky to be part of California because they also recognize the need for NICU follow-up as part of CCS-approved NICUs going all the way back to the late 1970s. However, that had been really evolving and changing. It was never a real clear, comprehensive program. There was kind of no stick that was involved if you didn't refer children. There was some confusion about what eligibility was. Basically, things were being faxed or not faxed to a central location. And many of us felt, starting in the beginning of the 2000s, that there could really be a better option for high-risk infants in California. And so CPQCC partnered with CCS and many stakeholders across the state to completely remodel this NICU follow-up program and develop the CPQCC CCS HRIF program. It has a long name, but we mostly just call it HRIF. So what did we need to build this program? And this program launched in fullness in 2010. Well, first we had to completely overhaul the high-risk infant follow-up structure because it had not been changed for many, many years. We had to clarify eligibility. One of our main goals was to create a completely new infrastructure for HRIF care, which included sort of a case management clinical infrastructure that would allow sites to be able to track and understand the patients that were coming and needed to come to their clinic. And this required the creation of a completely web-based system. This also allowed us to link to CPQCC and really start to build a framework for that continuum of care, especially through the lens of quality improvement. And that would take really actually maternal data and NICU data through the childhood trajectory. And all of these components were meant to support clinical care, site and statewide quality and process improvement, and identify barriers and disparities, especially in terms of social determinants of health. So who do we serve now? And I'm going to highlight some of these. Really, children and families are our main focus, of course, but high-risk infant follow-up sites are the members of our collaborative, which is a population-based collaborative with more than 70 high-risk infant follow-up sites across the state. And the state of California is also, of course, someone that we partner with. So for many of you, you really don't know what the eligibility are for high-risk infant follow-up. And I'm giving you an overview here, but I really want to emphasize the broad eligibility criteria that we have, which is great. And we were able to work with the state around this. But basically, every baby who is born less than 1,500 grams or less than 32 weeks is eligible and expected to be referred to this program. Similarly, those who are bigger with a range of medical eligibilities, including being on ECMO, congenital heart disease requiring surgery or intervention, a range of neurologic abnormalities, are eligible and expected by the state to be referred. And this is where the importance of the linkage comes in to the NICU side, CPQCC. So what do we collect in terms of information at these visits? So as I said, many people think of high-risk infant follow-up as, neurodevelopmental, neurosensory, but we really from the beginning focused on much more than that. We collect information about rehospitalization, surgeries, medications, resource needs, and importantly, whether children are referred but not getting special services and medical services, because this also allows us to feed back to the state and also allows the high-risk infant follow-up groups to make those re-referrals and get those patients in. There are a number of other things that we look to in our visits, but importantly, again, we look at parent concerns and we use that as a springboard to make appropriate referrals to social work, for food insecurity, even for legal services. In terms of the number of high-risk infant follow-up visits, again, here we are different in the state of California compared to other places and other groups. Our state provides for 3 standard or core visits, but there are many other visits that will be covered by CCS if determined as a need by the high-risk infant follow-up team. So we see the children early, kind of at the year point, and then also at that last time period, which is kind of the launch pad for them to go to the next services within the state and to exit high-risk infant follow-up. So that 3rd visit is very important. So how do we get all of this done is, as I said, we have more than 70 high-risk infant follow-up programs across the state that accept referrals from the many more than 140 NICUs, but we also have a huge infrastructure of support from volunteers, from groups across the state that we've developed for specific needs, and we'll get a little bit more into that. So at this point, we have more than 9,000 high-risk infants referred and registered in our state every year. So many children are referred for high-risk infant follow-up. And as you can see, all of these connections in the state of California have really allowed for an incredibly unique continuum of care that we can provide in this state that is really different from any other state in the United States. So now we're going to talk a little bit about the infrastructure of high-risk infant follow-up that's part of CPQCC. And we're going to start with that question, but we will also touch on these other aspects of research and quality improvement throughout the talk. So again, these are kind of nuts and bolts, but I want to give you an idea of what we have built, and importantly, that we couldn't have built without having an amazingly great individual who is our program manager, Erica Gray, who we are, connected at the hips for this program. So for those that are high-risk infant follow-up sites, they are able to log in and get a lot of tools and information in real time. So for sites that are logging in, for instance, this is where they land, which is over a many year period of evolution. This is what our clinical dashboard looks like right now. And this allows individual sites to be able to look at their entire portfolio of high-risk infant follow-up patients, including those that have been seen, those who have not been seen, and really give them a visual of where do I need to put my attention? Where are there challenges in getting some of these patients in? And this, unfortunately, I don't have to, I could probably spend a whole hour talking to you about this dashboard, but also gives them information about their clinic activity per month and where they are in terms of visits over time, first, second visit, third visit, and additional visits. We also have recently launched a health equity dashboard that is specific to high-risk infant follow-up. And this, again, is unique in the United States. It is not the same as the NICU-based health equity dashboard, but it does allow sites to, again, look at a glance at the race ethnicity distribution of their site and also be able to compare it to California. They could also look at it by language or insurance, and then they can look at a number of outcome factors. We generally have them focus first on follow-up rates, but as you can see, this mythical high-risk infant follow-up program has real disparities in terms of their follow-up rates at the first visit across race and ethnicity. They could also look at this in terms of services received and not received, and there are a number of filters that could be looked at as well. Also, high-risk infant follow-up sites, and in fact, NICUs can get access to this from the NICU lens, can look at their sites, again, in real time, and have a number of things that they can look at in reports. So they could select their own program or all California programs, and regardless, the reports are viewed with California there. They can look at how they could select by discharging NICU. They can filter by birth year or a custom birth year range, similarly to birth weight, gestational age, or a custom birth weight or range. They could qualify, they could look at just certain qualifying conditions. They can look at visits. And then this is really, the breadth of information that we have for sites to be able to look at in real time their own sites and compared to California. As I said, the NICU teams can also view this information from the NICU perspective. So this is just showing you that what we really try to encourage is for teams, NICU and high-risk infant follow-up teams, to share information, especially to allow the NICU teams to kind of gain an insight of what's going on for the children that they've discharged into the community who are followed by high-risk infant follow-up. And I'm just showing you a few snapshots of some of the reports that can be seen. So then I just want to move now to kind of quality improvement at research, which, as you know, there can be a lot of overlap in those areas, but I do want to show you how we are attempting to move quality improvement and understanding of what we can do better in California from within the CPQCC high-risk infant follow-up. So maybe one of the first things that we wanted to know when we first launched the new completely remodeled high-risk infant follow-up programs were we really meeting our objectives in terms of getting these children in, even referred to high-risk infant follow-up? And what we found was that the very low birth weight referral rate at NICU discharge, so these are children who were discharged from the NICU, was just 80%. So again, all very low birth weight infants in California are expected to be referred and are eligible. So we see this is shown across NICUs, and you can see there are some NICUs that are doing much better than others. And so there was really an opportunity for quality improvement here. More importantly, really, we saw great disparities, not just by site, but in terms of who was being referred. So of great concern, infants who were born to mothers who were African-American or Hispanic were much less likely to be referred than those that were born to white mothers. Children who had probably the clinical factors that include a perception of sort of having less of a need than others, those that were SGA, maybe they were small, but they were near 32 weeks or even over 32 weeks were much less likely to be referred. And there were also NICU level factors that were associated with likelihood to refer. So we could have said, well, let's just focus on those groups and try to make things better. But we really realized this was a statewide issue. We really needed to have a statewide and integrated solution. So what we did was we created what we call the high-risk infant follow-up NICU match summary report for all high-risk infants, or for certain areas of high-risk infants that were site-specific and confidential, and really highlighted to the sites, hey, you discharged this child who is eligible for high-risk infant follow-up, but you didn't refer them, so you need to refer them. So we had a 6-month pre-implementation period with a lot of education and feedback. We underscored our expectations, which was this was going to be a deliverable to the state after that 6-month period. And what we found was a great improvement. And this was an analysis that one of our former NICU fellows, Vidya Pai, who now works in the North Bay, led with us in the CPQCC. And you can see that blue dotted line, which looks very much what I showed you before, and that was pre-implementation. And the post-intervention is in red. And so there was at that point a change to 95% referral rate for very low birth weight infants. Now it is closer to 99%. Also, we were very happy to see that there was substantial improvements in referral rates across maternal race and ethnicity, as well as other clinical factors that I mentioned to you. Now, it has not removed the disparities. It has leveled the disparities in referral, but not completely removed them. So we of course still have work to do in that. I'm also very excited that we saw improvement not only in very low birth weight referrals, but also in infants with moderate to severe HIE, as shown in this analysis, and also improvement in the rate of follow-up to the first visit, which is very important to us. And I'm going to get into that in the next slide. So sometimes when I speak with groups, they kind of think about 2-year follow-up being the thing. And why is it that the first visit really is even interesting or important? Well, through the lens of follow-up, I would say, that early engagement really is important because it allows high-risk infant follow-up groups to identify challenges as they evolve and connect them with early intervention. Now, early intervention as a topic may encompass many different components. It can be a heterogeneous early intervention. It can be very focused. But I will say, and this is work that's from the Cochrane database by Alicia Spittle, who's in Australia, a meta-analysis that has been done now in several iterations showing that early intervention has a positive influence on cognitive outcomes for children through preschool and on motor outcomes at least through 2 years. There has also been a great deal of data that has shown that early diagnosis and intervention for cerebral palsy has motor benefits for children and a number of psychosocial benefits for parents as well. Another important thing for us in the first visit is something I alluded to before, which is sort of assessing medical and special services that a child needs. So this is an analysis that is just focused on extremely preterm, really extraordinarily preterm infants up to 25 weeks. And we can see here that that for those that are receiving at the first visit, they're walking into that high-risk infant follow-up first visit at 4 to 6 months, and many of them already have a great deal of medical services or special services that have been lined up for them, usually at NICU discharge. But importantly, what we also collect information about referrals that are made by the high-risk infant follow-up team. And as you can see here, to a medical service, the high-risk infant follow-up team, 1 in 7 to 1 in 4 times, and for a special service, 1/3 to 1/2 of the time, is making at least 1 referral. So without high-risk infant follow-up at that early visit, these children could have slipped through the cracks in terms of their needs and may not be getting the services that they require. We also have a series of I'm going to show you a couple of papers that demonstrate that getting connected early successfully also increases the odds of sustainability. And this was an analysis focused on rural location and whether that had an impact on getting to high-risk infant follow-up. And again, you can see that for the overall analysis, there were significantly decreased odds of getting to a second visit among infants of Black mothers compared to whites, those with public insurance, and those living in a rural location. But importantly, there was more than twice increased odds of attending a second high-risk infant follow-up visit if the first was within an expected window. So this again shows us that we may have the opportunity to improve disparities as well by making sure that everyone is connected in an equitable fashion for that early connection with high-risk infant follow-up. Similarly, we have demonstrated this for that important third visit. And that important third visit is, again, that visit before they launch to the next phase of the services and supports that they will get in the state of California. And this was led by partners across California, partnering with CPQCC and high-risk infant follow-up. And basically the one-liner that I really want to highlight is that in addition to other factors that were associated with sustained participation, almost incredibly, the relative risk of getting to that visit at least in that time period, was almost 7 times higher if they attended a first visit before 12 months of age. So again, this really highlights early engagement for all families. And Anna, did you want to comment on anything or before I move on? Or
there was one question from Ron Gibbs.
Okay.
Is the high-risk infant follow-up database linked to its CMQCC database? Specifically, could long-term follow-up be linked with maternal complications?
Yeah, so that's really a great question. There have been linkages done through data sets that the high-risk infant that CMQCC has. So yes, there have been analyses. There certainly need to be more. Something that we have been discussing. We're actually trying to find ways to connect CPQCC and CMQCC even more directly. But I will say, Ron, that we don't yet have a system whereby we could do what we would love to do, right, is, site-specific, real-time continuum of care looking from maternal complications to child outcomes. That would be like, that would be the ultimate goal. I agree, Ron. We're not quite there yet. We're at the phase of doing sort of statewide analyses to start to look at those questions.
Right. Well, it is a unique opportunity. I'm thinking, especially in terms of infant diagnoses that are long time in developing, like cerebral palsy, which cerebral palsy in a low birth weight infant, perhaps linking to maternal infection in labor and so on. It's really a unique data set. It'd be wonderful to try to make connections.
Yeah, no, definitely. Elliot, I think you were asking, and Elliot had a question. I think you were asking back a few slides, sort of what allowed that improvement in first visit attendance. And what we really felt was in that particular framework, the most important thing that we felt was critical in that analysis was that we were actually getting them referred. So the fact that that there was not really great referral, that we were educating the NICUs, especially on needing to refer, and thereby educating them on the importance of why we were asking them to get them to high-risk infant follow-up and what happens at high-risk infant follow-up also was important. I think in that particular case, in the slide that I showed, there were also a number of therapeutic studies that were coming out at the time, specifically about HIE. And so there has been a lot more focus on that patient population. But one thing I will say, Elliot, is that this is kind of integrated into our whole HRIF system of trying to identify important interventions that will allow us, and I really think this is going to be on a broader scale, and I'll maybe have time to get to this, a more focused on a statewide transition from NICU to home and community type of intervention that would bundle a number of the interventions that we feel would support families in getting to the first visit. And that, I'll just pivot to say that, your question, Elliot, is linked to this was a survey-based study that we did to try to understand what were challenges for the sites in getting families in, and also what were challenges for families. And just I'll give a few highlights of that. I'm not going to go through the whole study at all, but I think there are many barriers at the site level that have not been, clearly supported and delineated, because high-risk infant follow-up clinics aren't loss leaders. They are not money makers. And so even though we have recommendations from the state about administrative schedulers, clinic coordinators, et cetera, there is a wide variety of support at various clinics. So that alone doesn't allow them to engage with the families as much as they would like. And then in terms of resource and other needs and barriers, there is limited availability for HRIF clinic times, and this was pre-COVID, which I'll get to, and limited personnel for tracking, which is obviously a major issue, but also really parent challenges are massive. So this was really teed up for us when we did this study of saying, okay, let's start to discuss and connect with individual high-risk infant follow-up sites to see if they have satellite clinics. Some sites did, some sites didn't, and our discussions with them did allow some sites to start to launch satellite clinics that were kind of closer to where their families were, rather than having the families come in. And then, also discussions with the families, how can we interface with them earlier better? But I just wanted to highlight a little bit here before we close out what we had to do in COVID time. And that really, I'll just very quickly, because I see we only have 5 minutes, that we really had to pivot our quality and process improvement issues, especially given the fact that HRIF up to this point was virtually completely face-to-face. And so we really needed to understand what options there were for sites to continue to connect. And this was really a multi-stage project, allowed us to really get a lot of information from the coordinators, from the sites themselves, and to also put together an interdisciplinary work group that allowed us to develop guidance for CCS high-risk infant follow-up sites very rapidly, and also change our standard visit to include telehealth validated visits, which now I will say this, there was a very wide array of uptake, but some of that was because of the clinic's proactive stance in saying, this is not right. I know that this will not work for my patient population, so we are therefore going to launch home visits or some other situation. But I would love to talk to you more about this as well, because this alone has a huge impact, because we have seen sites, and we actually are encouraging this, continue for some of their visits by telehealth, because it will allow families to remain more engaged. I also just want to tell you briefly that we also did a survey-based study of parents of infants born at less than 30 weeks during the early COVID period. And this was supported in part by the Office of Faculty Development, Diversity, and Engagement for a pilot project. There's a lot of data here, but I do want to say that we had some open-ended questions for families that really gave us a huge amount of information for where we can go from here and actually apply this for non-COVID times. So that, I think, these are just 4 items that we're really going to be moving toward and moving forward with in terms of quality improvement in the California high-risk infant follow-up program. And that includes supporting parent mental health and family voices, integrating family voices even more aggressively. And some of these things we've really learned from some of the research that we did and the family-based surveys that we did during COVID. I'm just going to stop there, because I really would love us to have a chance to get through the rest of these questions. And also, so a great tee-up question, Dr. Drusen. Yes, telehealth has been implemented. As we said, I just will say that it was really important to us to do this in a way that was thoughtful and to do it in a validated fashion. So this was some of the reason that we had this subgroup to create guidance and to make sure that we selected the instruments that were appropriate for telehealth and had been validated. As I said, some of the sites are continuing this, especially maybe for first check-in or for extra visits, to be able to maintain better communication with families.
Thank you, Susan. I think that the challenge for so many of our patients is the travel and the distance. So this is just a good solution for many patients to be able to use telehealth.
Yeah, and as I do want to indicate though that some families do, that is a great solution for some families. Obviously, there are some things in high-risk infant follow-up that are difficult to achieve. A full neurologic exam, for instance, by telehealth, but there is a lot that we can do by telehealth. Having said that, I think the incredibly valuable feedback from the high-risk infant follow-up sites just underscore the diversity and the variety of patients and families in California. Some sites have been very concerned that they would not be able to achieve the goals that they need to, and the care that they would need to meet their families' needs with telehealth. And, we are basically in process now of doing some, post-COVID evaluations as part of that analysis I briefly showed you, to try to understand whether attempts were made or not with all sites, or if there really have been some sites that have picked it up even after the initial period of COVID.
Any other comments or questions for Dr. Hintz? Thank you, Susan. I personally learned a lot. I know that you've done phenomenal work in leading this work, but yeah, thank you so much for coming and sharing.
Thank you so much for inviting me. It was really an honor. Thanks very much.
Thank you all for joining too.